Hello everyone, our drug is methotrexate and it's by Chenoa and McKenzie. Methotrexate is an anti-metabolite, so it works by slowing or stopping the growth of cancer cells and suppressing our immune system. Methotrexate has a wide variety of indications. It can be used for cancer, either breast, skin, head and neck, or lung, psoriasis, rheumatoid arthritis, juvenile rheumatoid arthritis, medical termination of pregnancy, and this drug is usually given after other medications have been tried and failed because it does have a high toxicity and there's a lot of different precautions you have to take with it.
Dosages. The dosage and how often you take this medication are based on your medical condition and response to treatment. This drug should not be taken every day, and you must use the correct dose for your condition. Administration. This drug can be given orally, through tablet form or liquid form, and you can store the tablets at room temperature, and the liquid can be stored at room temperature for up to 60 days, but lasts longer if you store it in the refrigerator. It can also be given subcutaneously or intramuscular, and it can be given with or without food.
Methotrexate on this here are some
Precautions and contraindications. Do not use to treat psoriasis or rheumatoid arthritis if they have low blood cell counts, a bone marrow disorder, a weak immune system, liver disease, especially caused by alcoholism, if you are pregnant or breastfeeding. While on the medication, avoid drinking alcohol, which increases your risk of liver disease. Do not receive a live vaccine while using methotrexate. This could cause you to develop a serious infection. The medicine can pass into bodily fluids, so caregivers should use precaution and wear gloves when cleaning up bodily fluids and avoid being in the sun. Drug interactions. This drug can harm your liver, especially when used with medications that treat infections, TB, depression, birth control, hormone replacement, high cholesterol, heart problems, high blood pressure, seizures, or pain or arthritis medications, including acetaminophen, Tylenol, Advil, Motrin, and Aleve.
The adverse drug reactions can include loss of appetite, nausea, vomiting, drowsiness or dizziness, pulmonary issues, hematologic disorders like unusual bleeding, liver dysfunction, hair loss, GI issues, bone damage and pain, fever, chills, mouth sores, or shortness of breath. Here's a few more that you should be worried about. Kidney problems like little or no urination, swelling in your feet or ankles, dark urine. It can affect fertility, and mouth sores.
Drug monitoring. This is a drug that needs to be monitored. Initial monitoring starts every 1 to 2 weeks. Once therapy is stabilized, patients should be monitored every 2 to 3 months. These patients should have a full blood cell count and renal and liver function tests completed. Special considerations: presence of pre-existing liver damage or impaired hepatic function. If you are pregnant, do not take this medication. Do not take if you have liver damage.
When a patient is on methotrexate, it is important that we take into consideration a few things when we're completing therapy with them. We want to first be able to assess pulmonary function periodically by measuring lung volumes, breath sounds, and respiratory rate, and you want to notify the physician if you notice that anything is wrong with them. You want to monitor any unusual fatigue and weakness that might be due to things like anemia, leukopenia, or thrombocytopenia. You want to report signs of arachnoiditis, especially following IT administration, and then the signs can include tingling, numbness, or weakness in the leg, strained sensations, muscle cramps, spasms, or twitching, and bowel, bladder, or sexual dysfunction. Here are a few more PT implications with patients that are on methotrexate. You want to assess any musculoskeletal pain that could indicate osteonecrosis, a stress fracture, or soft tissue necrosis, and also report any signs of musculoskeletal lesions that might warrant for a referral. If you're treating a patient that's taking methotrexate for rheumatoid arthritis, you want to assess their impairments like pain, range of motion, functional ability, and disability so that you can document and see if this drug is actually working and being successful for them. If the patient is on this drug for psoriasis or any fungal infections, you want to assess the healing of skin lesions, again to help document if this drug is effective for them. And then you also want to assess dizziness that it might affect gait, balance, and other functional activities. And you want to report balance problems, functional limitations to the physician, and caution the patient and family caregiver to guard against falls and trauma.
Supplements to be taken with methotrexate. Folic acid is depleted by methotrexate. It is important to be replenished through supplementation. Folic acids prevents red blood cell abnormalities and anemia.
In the next slide, we're going to talk about methotrexate usage trends in psoriasis, a retrospective study. Here's an overview of the study and just the main points that I took away from it. So psoriasis is a chronic inflammatory papillosquamous cutaneous disorder that has both genetics and environmental factors. And then methotrexate, which was used to treat psoriasis, is an anti-psoriatic agent given for chronic plaque type psoriasis. So it was seen to be fairly effective in improving psoriasis in about 75% of the patients. The patient population in this study was 56 male and 30 female. The most common adverse reaction was a GI upset, and they concluded that methotrexate is still seen as a gold standard therapy for psoriasis. Some other considerations I thought was important is elevated liver enzymes were observed when the doses exceeded more than 1,500 milligrams over a period of 104 days, so that's something we have to be careful with and note. There was no significant drug interactions noted in the study. It is important that these patients are on folic acid supplementation since this drug stops folic acid breakdown. The study concluded that methotrexate at a low dose, so that would be less than 15 to 20 milligrams per week, was an effective treatment for moderate to severe forms of psoriasis.
Another study that we looked at is clinical genetic model to predict methotrexate intolerance in rheumatoid arthritis patients. Overview of study. Introduction. Methotrexate is a gold standard DMARD in rheumatoid arthritis but is often associated with mild adverse effects like intolerance or laboratory abnormalities. Although non-life-threatening, they are responsible for drug discontinuation in 17 to 50% of patients. There is limited data on clinical and genetic markers that predict their occurrence. Methods. The study enrolled patients with active rheumatoid arthritis and they were started on methotrexate at a weekly dose of 15 milligrams and were gradually increasing their dosage until they reached 25 milligrams. They continued at the dosage of 25 milligrams until the end of the study. Intolerance was measured with a questionnaire at 4, 8, 16, and 24 weeks. Testing for occurrence of cytopenia and for transaminitis was done at the same time. Alright, and then the results of this study included 110 patients with RA who received methotrexate for 24 weeks. The final mean weekly methotrexate dose was 22 plus or minus 4 milligrams. Methotrexate intolerance occurred in 40 common being nausea and vomiting in 29 and anxiety and dizziness in 9. A model including BMI and FPGS could modestly predict methotrexate intolerance with an accuracy of 66.3%. So in conclusion, a clinical genetic model including BMI and SNP FPGS 10101 was found to have a modest prediction ability for methotrexate intolerance. Methotrexate intolerance symptomatic adverse effects was common and occurred in 37% of patients over 6 months. SNP FPGS RS, a low body mass index, were associated with methotrexate intolerance. Clinical genetic model had a modest ability of 66% for predicting intolerance. And here's our references.